Welcome everyone to the Precision Medicine Throughout Your Life, Senior Living and Beyond webinar. Genexus is delighted to host this educational webinar. If you have any ideas for future webinars or would like to be a guest, please email us at the Genexus educational team at info@genexus.com. Now I would like to pass it on to our host. Over to you, Dave.
Thank you, Manning. Hello, everyone. I'm Dave Wolfe, Director of Business Development with Genexus. And, we at Genexus provide the world's most comprehensive precision prescribing solutions with embedded pharmacogenomics and genetics to solve one of healthcare's biggest challenges, inappropriate prescribing. Our CDSS, or our Clinical Decision Support Suite, is in use by several insurance companies, PBMs, health systems, pharmacists, pharmacies, and also pharmacogenetic labs throughout all of North America. As we all know, polypharmacy is associated with a high level of adverse drug reactions. We also know that due to the number of medications that our seniors take, and you can loosely define seniors, that the drug-drug and the drug-gene interactions are more likely with that patient population. As expected, it turns out the precision prescribing and pharmacogenetics has a very positive effect on these health outcomes with this patient population. I'm excited about today's webinar. Today we'll be focused on senior living and the way the precision medicine and pharmacogenetics aims to support and improve our patient outcomes. The secret truth is that those same tools can be used with any patient population, but today we're going to focus on the senior living. I'm excited to bring this group of my pharmacy brethren. I'm a pharmacist by background as well. We've got an outstanding panel today, and I'm actually going to introduce each one of you individually. And if each of you can tell a little bit about yourself. I'm going to start with you, DeLon. Dr. DeLon Canterbury comes to us from North Carolina, unless he's still in the UK. I think he's back. Welcome back, DeLon.
Thank you.
He's the CEO of Geriatrics Incorporated. DeLon, just if you can get a little background to yourself, would be really helpful. Thank you.
Yeah, absolutely. Again, appreciate being here. Board certified geriatric pharmacist. I started geriatrics in 2020 after being a burned out pharmacist. I was in retail at Walgreens since 2014 after graduating from UNC Eshelman School of Pharmacy, where I actually met Dr. Howard McLeod, who was actually one of my mentors when I was a student at UNC. So I literally love and stalk this guy at the same time. But either way, I've been in this business for 4 years and felt that I, as a retail pharmacist, was kind of contributing to the issues of polypharmacy. And where I work, we serve primarily seniors. So I am honestly pleasure to be here. I just kept seeing time and time again how much drug interactions, polypharmacy, prescribing cascades I was attributing to, and felt there had to be a better way. So I decided to step down, create this company to provide concierge de-prescribing services. And so I do two things. I work with families one-on-one who are looking for my opinion around medication de-prescribing. And of course, I also train other clinicians and pharmacists, nurses, how to monetize and leverage the prescribing, particularly using genetic testing as a tool for that. So pleasure to be here and looking forward to chatting.
And DeLon, I understand you have a nickname too. You're the de-prescribing pharmacist, right?
That's right. That's right. That's right.
That's just a piece of the puzzle you work on. That's right.
There you go. There you go. There's plenty like us, but yes, that's what they call me.
Welcome. Pleasure to have you on the panel. And now I'm going to introduce the mentor, Dr. Howard McLeod. Dr. McLeod is a director for the Center of Precision Medicine and Functional Genomics at Utah Tech University. He serves as an advisor for Intermountain Health, as well as several other organizations. Howard, do you mind introducing yourself and welcome to the team?
Yeah, thanks, Dave. It's great to see you and great to to be with you. You're one of the few people lately that I met in person first,
That's
and then
right.
online, whereas that's a rare thing these days. So it's great to be with you again. In addition to being a fanboy for both DeLon and Thu, been active in the precision medicine space. Some on the discovery side, some on the validation side, policy, and then implementation has been a lot of it. And a lot of the themes have been, how do we democratize this? How do we make sure that a small clinic in Wyoming can get the same thing as they can at UNC Chapel Hill, where DeLon trained? And so that's a lot of the effort now is, how do we make that happen? Some of it is some commercial platforms, as you can see here, some of it via the academic route, the .org route. But the overall goal is making it normal for this sort of patient safety to be occurring. Genetics isn't everything, but it is something. And so making it useful when it is useful is kind of the theme.
Thank you, Howard. Appreciate it. And now I've got the pleasure to introduce Thu Nguyen, Dr. Thu Nguyen. Thu and I did a podcast on transition of care, and that fits in this topic really well, Thu. Can you quickly introduce yourself, please?
Good morning, everyone. Thank you for having me today. I'm super excited. I'm someone that's been interested in geriatrics and transition of care since I was a pharmacy student. So I've really followed that passion through my career, and I'm really just honored to have the opportunity to talk about this and share what I know for everyone who's interested. So excited to have this conversation with you all.
Thank you, Thu. Let's just kind of get started. I'm going to throw out some statistics here just to kind of talk about this patient population. Here's some statistics around senior living in the US. There's almost 16,000 senior living facilities, according to CDC in the US. About 1.3 million patients reside in these settings. And there's a lot of turnover in those settings, changing facilities, different levels of care, like 45% patient turnover in these different settings. And over almost 40% of these patients are considered polypharmacy. They take 5 or more medications. So it really kind of sets the stage for how we can optimize and use the knowledge of this panelist team to really improve the care in this growing and critical patient population. I'm going to start with some terminology, though, because this is where a colleague of mine said we need to call this senior living or senior care. But I've heard terms like long-term care, LTC. I've heard nursing homes, skilled nursing facilities. Do these all fall under the one umbrella called senior living? Just looking for some feedback from the panelists. Or is it a whole continuum?
In my mind, it's a continuum. I live in an area where there are a fair number of seniors. Some of them are incredibly active and can beat me at pickleball. Some of them are quite debilitated and in some cases even bed bound, and so that whole spectrum kind of falls under there. Obviously, those who desire to be more able are the ones that are more straightforward to help. But I see a big spectrum. But I love to hear from DeLon or Thu on that.
Definitely a huge spectrum where I believe the power of genetic testing and even deprescribing alone can integrate into most of these care settings. There's retirement living communities, independents, there are assisted living facilities, that there are continuing care homes. I mean, there's an entire burgeoning field within the senior aging industry, and they all are rife with opportunity for us to use some of these awesome services. But what I have found too is that physical therapists are looking into this type of stuff. Like, we're seeing more holistic medicine. They're really non-traditional thing that we think of in this interdisciplinary role that can have impact here. And that's where I think all of us, have a role to educate others about the power of this. So I'm seeing a huge continuum as well. Completely agree.
Yeah, I think when it comes to senior living or senior care, we really have to not put everybody in one box. So it's really crucial, especially when a lot of times we use age as the determinant to treat somebody. That's not an appropriate marker to determine the treatment that we give our patients. And so something like precision medicine, that's really crucial. Even even in various practices, I've seen that even in cardiovascular disease, for example, we're using biomarkers now to identify which patients are at risk for a cardiovascular events, and no longer using these population calculators anymore, because we were finding that they're not as appropriate, especially in older patient populations. So definitely it's a big spectrum, and we need to be aware that everybody has their own individual needs too.
No, fantastic. Thank you, all three of you. It's, I've heard the terms deep prescribing. You guys talked about polypharmacy. What does precision medicine support look like? And I think, DeLon, you brought it together with, it's a collaborative, professional collaboration going on here. And it used to be, oh, I'm going to send grandma to the home. And it's not the case anymore. We can continue to take care to give them the most successful life outcomes through that collaborative approach. What are some of the tools you guys have seen used or services provided that really drives towards this precision medicine support?
Well, I guess I'll jump into while the others prepare. I think one of the elements that we've seen is a way for the patient's information, at least their medicine information, to be more portable. One of the things that a healthy senior has in play is typically a number of different clinicians that they interact with, whether they're at a physician's office or a pharmacy or physical therapy, et cetera. And there's a portability issue that can be in play there. And even something as simple as medicine reconciliation is a challenge. I remember when my mother broke her ankle, the ED asked her what medicine she was on, and she was on a water pill and a sugar pill. Right. And she couldn't quite remember which color they were. And finally had to call my sister away, 1,000 miles away, and who drove over to her house and looked in the cupboard. But there's elements like that are boring, are not real exciting pieces, not as exciting as some of the other stuff we're going to hear about next, but are really important to maintain some precise decisions around these patients.
Fantastic. DeLon, what are some of the tools you use in your practice? Yeah.
Oh, yeah. I like to focus on educating and empowering. And I think another example I've seen are some pharmacists using pharmacogenomics within some of these long-term care facilities. And so trying to get that built for is another conversation. However, it is doable. And so we're finding ways where we can put some of these clinical studies to actual practice and showing some of those cost savings. And what I see, particularly in our seniors, we have a lot of mental health issues, and we're quick to throw on an antidepressant. And I mean, frankly, just yesterday, I have a client who was given for instance, I'm more community facing, right? I do more consulting one-on-one, but she was given fluoxetine. And I was, mind you, advocating for them 2 months ago, hey, you got to get this PGX test done before you just get something thrown on. I know she's got some things declining, some cognitive impairment, but let's talk about that. The office had the kit just sitting there, didn't do it, but just said, you know what, let's just start her on fluoxetine, literally a 10 milligram dose. When I tell you her dementia became worse, started sundowning, and then we ended up getting the report after the fact, which is what we're trying to go against. And we're able to see, oh, wow, she's a 2D6 or metabolizer. So a lot of medications fall into that category. And she wasn't the best candidate for that fluoxetine. And so she failed therapy. and literally had a blank stare, had a weird tic, and had worse sundowning. And all of this could have been done with an accessible and covered test. So I am more on the education empowering piece and showing people that there are other tools to get it. They sent me that report and I saw exactly why she failed within just a minute. And that's the power, again, pharmacists have in this mission. And what you guys are doing with Genexus is showing that this is more holistic and it affects everyone's outcomes in the way.
Fantastic. Great example. Thu, can you think of some examples similarly?
Yes, definitely.
I bet you can.
I work closely with physicians all the time. So when we're talking about reviewing a patient's medication list and assessing for appropriate therapy and hopefully to de-prescribe some of the inappropriate medications, we need a lot of information to make sure that our recommendations are appropriate. And precision medicine and pharmacogenomic testing is certainly an important factor for us to use that evidence to make a stronger case for reducing some of these medications and inappropriate use. So the more information we have to make sure that we are giving the patients the right therapy, the better, and it provides a better communication for me and the provider or the doctor that I'm working with too, because I can show them clear evidence of this is specific to this patient and we need to address, some of the issues that can come up. So I think it will benefit me a lot in a clinical practice for sure.
Mhm.
Yeah, and I'm thinking that, pharmacogenetics is just a piece of the puzzle, especially with this patient population. And Thu, you made a point earlier, we can't just base it on age because it could be, similar functionality or dysfunctionality irregardless of the age. But liver function, kidney function, all the things that impact the metabolizing of a medication is critical here. And trying to get that information in this disparate world we're in. And Howard and I were talking earlier. I wrote a paper in 2006 on the lack of interoperability, and we're not quite there yet. But we can be the conduit as pharmacists to get some of that, pull those pieces together.
Yeah, we need the full picture for sure. And I always find that when I'm making a recommendation to a provider, especially coming from a pharmacy perspective, that the more evidence we can provide to the provider, the easier that conversation is going to be. And then it helps pharmacists to showcase what we can also bring to the table as well. So if we have those tools, then it will really benefit in the long run.
Education is key here. And it's not just education of the patient, but it's also to our partner providers, correct? DeLon, you're at a patient's home, going through the care of a patient. You've got to work with multiple providers that patient may be seeing. What are some of the tools that you use to communicate with that provider? And give us some lessons learned there, if you would. He didn't know this question was coming, but I think that's key, is how do we collaborate with the providers?
Yeah, no, that's really where it counts, right? And I think Thu made the best example of discussing how you have to build a case. You have to give that evidence. You have to give it to where it's a softball, slam dunk, easy. Okay, I see why. And just last week, I'm discussing some of the benefits around pharmacogenomics, how this can maybe save some more lives in your clinic. She, mind you, had a concierge cash-only clinic. But the best way I'm able to honestly educate is to show them. It's to get a sample kit to those doctors. I want them to test it themselves so we can go over it together and show the extrapolation of this evidence to your clinics or to your patients. For me, I like to look at case vignettes, of course, what I've seen with my own personal patients. But I'm here to show how this can save their headache and time and resources and energy and effort, because you all know there are competing priorities. There are tons of other things we have to worry about. They're not necessarily in the space to just learn a whole new skill set. Let me take off your plate. And that's the piece that pharmacists have to get comfortable showing, is not just our value, but like, yes, we can save you some bottom line. We can save you some time, energy, and save on those indirect costs associated with running a business. And when you're able to communicate that pain point, in addition to helping with your outcomes, it becomes a slam dunk. And that starts with building trust, that starts with education, that starts with relationships. But I like to first start with what I've seen, what my patients are seeing now. But I love to just softball. Hey, you want to get a kit yourself? We can get you a sample. We can just see what this looks like and then run through how this can be an issue. And I like to give examples and hypotheticals. Like, hey, look, if you had this deficiency in 2D6 or 2C19, this is how this will affect your pain management. This is how this will affect your antidepressants. And show those cost-saving studies that are out there too. It's hard to have pharmacoeconomic studies, but show some of that data too, so they have some tools to read at home and say, all right, DeLon was right. Let's go forward. So you do need to have a little bit of coddling and then meeting them halfway with where they are. So Thu, I think, slam dunked it with building a case and making it easy for them to make that intervention.
Absolutely.
I think there's an important thing that you'll notice DeLon didn't talk about, and that is the history of CYP2D6 and why the star 4 variant is interesting and all that. It's most of my physician colleagues, they just want to know what to do. They don't really care about a lot of the nerdy stuff that I care about. They just want to know what to do. And they want to know it in a timely manner, and they don't want to know there's concern. They want to know what to do. Don't use this drug, use this drug. And that's the more we get comfortable with actually guiding, as opposed to, like the drug interaction level stuff where it's like, there's a concern somewhere in this darkened room, see if you can find it. But rather, here is the problem, here's what to do. And that's that kind of education goes a long way. If they want to nerd out with me on the history of gene, sure, we'll do that. But that's for afterwards.
That's right. They want to know what to do versus what not to do, right? And it's like, okay, I see this test that says I shouldn't take these medications or use these with caution. Which one should I use? And that's where we can help them, we as pharmacy, as a profession. The other education piece here, as I think about senior living, it's not just the patient, but it's the caregivers, the extended family, it's the children of the parent, and helping educate them as well. Because many times the senior may rely on them. Do you guys have any examples of where you've been able to educate them? I'm going to use caregiver broadly. And it can be, me living in North Carolina and my mother's in a home in New York. How do we collaborate with that as well?
I can't even lie. Thu, go ahead. You go ahead.
Thank you. When I talk to patients about medications, especially in our senior population, one of the first questions I always ask is, who helps you manage these medications? I think that should be one of the first things you ask before you even dive into any medications or, therapy or anything like that. Because you want to make sure that the patient has enough support, but that you also want to make sure that you're spending a lot of energy on the right person as well, because they may be the ones to take care of most things. And then that's when you can put in a lot of effort into that person. So for me, when it comes to addressing patients and their family members, I work in the hospital setting a lot of the time. So if I see them bedside, that's a really great opportunity. And it's always really interesting to have that family dynamic, because you can really play off of each other and say, well, your daughter said that you didn't really take this medication. Can you expand on that? And have that family member be part of your team. I think that's such a great tool to kind of all work together like that. So I love working with family members, especially in a geriatric setting.
Absolutely.
The family members care about their loved one, but they also care about themselves. And there's a bit of a teachable moment in the case if someone has a BRCA1 variant, you immediately think about educating their family, whether their cousins, their daughters, et cetera, about breast cancer risk. But if someone is a CYP2D6 poor metabolizer, it's not always the top of mind to make sure that the family understands they have a high chance of having something of interest there too, and that might be a higher yield for them to start their testing, even though they may not even have prescriptions yet, and now be in a preemptive state. So there's a little bit of a discussion there. I've also found the pharmacogenomics, you're exactly correct. It's a small part, in some cases a very small part, in some cases bigger, of the care, but it's personal. It's their mom's DNA, or it's their brother's this and that, and so it allows a different type of discussion, that it's not average data from a New England Journal article, it's data from her. And so again, a real nice family discussion there. And then lastly, there are some apps and others, a growing number of others, where you can do almost like a family share approach, where you can see what it looks like for your mom and for your kids from the same app. Because often you get a certain age where you're still managing your kids and you're managing your parents. So it ends up being really useful that way, especially when, like you mentioned, the geography issue.
Absolutely.
Mm-hmm.
Let's transition into transition of care, if we could. Manning. Thu, I'm going to start with you on this one.
Yeah.
So if you look at this patient population, it's full of transitions of care, right? It could be inpatient, discharged to a rehab, discharged to a skilled nursing facility, back to rehab. Talk to me about some of the challenges here and some of the successes, more importantly.
Yeah, let's talk about both of those. Especially in our geriatric populations, they are the ones with the most exposure to our healthcare system. And our healthcare system, I believe, is just not, there are too many gaps within the healthcare system to take care of them back, unfortunately. So there's really suboptimal care. The thing is, we can provide patients with the right treatments, the right therapy, the right testing, pharmacogenomic testing, but unless they understand how to actually manage all of that, there's going to be gaps in the way. So you can give them the right insulin dose, for example, but if they don't even know how to use insulin at home, they can't even pull up the right dose, things like that, it's going to just, everything that you've worked for, that's just going to go to waste. So you really have to see the patients as a whole picture when they're navigating through the healthcare system. So transition of care talks about when a patient is exposed to any healthcare setting and then goes back to home or goes back to another healthcare setting. Each of these areas, they're transitioning between one care to another care. So you can kind of see how it can get very complicated, especially if there's nobody managing the whole picture for them. So this is why family members are really important. This is why you need to have a lot of hands-on. DeLon going into a patient's home to help with medication therapy. That's so important because these patients do need a lot of help. Areas where it's working really well, I mean, things like deprescribing pharmacy, where pharmacists are really taking the reign of that and making sure patients are on the right medications, even medication management, like MTM, for example, medication therapy management, calling patients at home and having those conversations with the patients. These are really great areas, but the thing with transition of care is because this is about the whole healthcare system and how patients navigate through it, everybody needs to be on board, including the nurses, up to the doctors, to the chief medical officer of a facility of the health system. We can't let them fall through the cracks, because then that can worsen their health, but then also there's a huge financial impact and burden on the healthcare system as well. So a really good example would be a patient of mine who came into the hospital because they had low blood sugar, because the primary care provider, or whoever it might have been, had increased their insulin and it dropped their blood sugar too low. They fell, they ended up in the hospital. Then the hospital doctor decided to decrease the insulin and sent them back home to manage the low blood sugar. And the patient came back with diabetic ketoacidosis, which is DKA. Both of these things are very severe. A fall for a geriatric patient can lead to numerous health issues. DKA can be deadly. So I'm not talking about just some, simple, oh, we just need to do more education. There is a whole entire health system that needs to change for the better care of our patients. So I am very passionate about this topic, obviously, because I see this so much, and I want to make sure that people are aware that this is a huge impact, especially in our senior patients, because they have so many health conditions and a lot of medications. So a lot of things can go wrong.
Absolutely.
One element that's often missed in this the transition are the other clinicians that are involved with it. The physician-pharmacist relationship is often highlighted and is typically in place at some level. But I found that occupational therapists are not only important for this transition, but they are being tasked with having to think about medications in ways that they're not comfortable with and they're not prepared for. And so having if you're involved in the transition of care, you need to be involved with the people who are helping make that transition. And the OTs are just one group. I think pharmacy needs to get to know better, and medicine needs to go better, because they are an important part. And that's one group. There's all sorts of people that you end up seeing in the cafeteria, but don't necessarily know how to work with. And that's yet another group we need to be paying attention to.
That's a really good point. That's very true. I work with social workers a lot when I do transition of care. Those guys are really important case managers as well. So yeah, we all need to work together to get this done for sure.
Couldn't say it any better. That is exactly why I created the D-Prescribing Accelerator, is to get these non-traditional roles involved in the D-prescribing process. PT is just as invested in stopping falls risks as a pharmacist is in an older patient. So why don't we have more pharmacists teaching PT and OT to use and watch out for some of these medications? Well, hey, that's what I'm doing. That's currently what's going on in my cohort. We have a current social worker who's going to be a certified D-prescribing advocate as we speak. So my point is, everyone has a role. It doesn't just have to be a pharmacist, physician, dyad. We can have medical assistants. I envision a world where there's D-prescribing pharmacy technicians. Seriously, we can do this. So the relationship between PT, OT, geriatric care managers, there's so many levels to this where our expertise is needed, that we gotta just stop thinking, oh, hospital, LTC, that's it. There's so much more. So the power of understanding, like people who help with placements, like people don't understand that some facilities will not take you if you're on a certain medication.
Yeah.
And that's the thing you don't know. If you have someone who's a D-prescribing specialist or genetic testing person who can find and screen, hey, here's why they're having those issues, you can save some people money, get them placed faster. And as you don't know, there's a bottleneck in getting people into some of these facilities. So this is where strategic partnerships matter, and then thinking a little bit outside the box, because social workers are just as important here. Geriatric care managers, just as important. They facilitate the transition of care. So if you have a pharmacist doing this type of work with them, you don't have to worry about clients because they already have them. You don't have to worry about billing because they could probably afford you. It's a cash model. And that's why I believe the community has much more, because we have 93% of seniors living in a community. It's much more than just hospital and LTCs and SNFs. And that's where I feel D-prescribing needs to go. And genetic testing is a critical piece. So they all integrate pretty well.
Yeah, and our clinical colleagues can be our eyes and ears. Many times they're doing the home visits. DeLon, you do some home visits, but many pharmacists don't. Yeah. So they can be the eyes and ears to take care of Thu, to take care of DeLon, to take care of Dave, because they know Dave, they know Thu, they know DeLon. And somebody's trying to figure out Howard, but we'll figure him out eventually. That's right. That's right. But it's anything else around transition of care, Thu or team?
I think we hit the nail on
carrying this torch, Thu.
Yes, I appreciate it. Yes, definitely.
Absolutely. So what are some new trends that you see in precision medicine? And, I'm thinking of things like the CDSS, collaborative practice agreements. What are some new trends that you see going on? And I'm starting to see pharmacists more embedded in some of these senior living communities or those transition communities. where traditionally it'd just be the pharmacist doing the monthly med rec review in a long-term care facility. So I see it evolving. What are some trends you guys are seeing?
For the places that are already doing pharmacogenomics, I'm seeing them look at additional information that could be obtained from that same test. So if you're using a test that only looks at a specific pharmacogenomic markers, that's all you have, and that's all you wanted. But some of the platforms that they're used out there also have additional risks there. So it might be familial hypercholesterolemia genetics, or it might be hemochromatosis, iron overload. Some of these things are not as obvious. It's amazing how few people get their cholesterol tested, and so may not know that they have a cholesterol of 400 because of their genes. And there's things like that I'm seeing added. The other piece is there are now genetic tests to try to do early detection of multiple different types of cancers. And so this has nothing to do with pharmaco, but it's very much precision medicine. And what I'm seeing is that the clinical pharmacist who is leading the pharmacogenomics endeavor is now seen as the only one that can spell DNA. They're now the expert. And so they're being asked to help with some of these other pieces, and which is a great opportunity for pharmacy if pharmacy's ready, because no one else in the community is ready to do this or wants to do it. And so it's really expanding the book of business, if you will, a little bit farther. So it's really been interesting, especially in the senior setting, that early detection of cancer, a blood test type detection, is much more practical than sending someone for mammography or other things. Now, it doesn't replace those things. I'm not saying you should stop doing any of those things, but there's some simplicity that you can get from a blood draw that you can't necessarily porting someone over for a colonoscopy or Cologuard even.
Yeah, outstanding. What are some trends you guys are seeing? Go on.
I've seen some interesting research out there in terms of precision medicine and individual patient care, would be in the primary prevention setting in cardiovascular disease. The guidelines recommend using the coronary artery calcium score a lot of the times, especially on our geriatric patients, to determine if we even need to be managing primary prevention with a statin therapy or maybe even an aspirin therapy. So that's really important. There's been a lot of debate whether or not the ASCVD risk calculator scores are even appropriate for our older patients, because that's a population-based risk stratification method. And a lot of times our geriatric patients are not involved in that kind of research. So guidelines have a cutoff of 80s or older, and clinicians are left to wonder, what do we do with these patients? And so there's been studies suggesting that maybe some sort of troponin test or like a procalcitonin test could potentially be, or not procalcitonin, sorry, the BNP, NT-BNP test to help identify which patients are at risk for a heart attack or stroke, instead of using our typical ASCVD risk calculator.
I'm not as specific as those. They might be more in depth than but I am getting generally more inquiries from my older population about a genetic test. They get all types of advertisements,
Yes.
spam, news, emails, fraudulent asks. And so I am seeing an uptick of people generally wondering, what is this? What does it mean? It's not ancestry.com. No, it's a little different, but I am getting more inquiries. And as you get more inquiries, you're going to get more providers wanting to know, what can I really do with this information? So apart from like the clinical stuff, I feel like I can't really add much more than what I'm seeing from the community side, really, other than more questions. And that's where we have opportunity to help educate.
Yeah, it goes back to education again, DeLon, right? Every chance we get to educate, because they are inundated with, you mentioned spam, I get the call from my mother saying, "Hey, I just got this email. Should I open it?" No, don't open that one. It's And but we can play that, well, when I graduated from pharmacy school several decades ago, pharmacists were the most trusted profession. And I think Howard would remember those days as well. And I think we're getting back there again. And people are coming to us as the trusted clinician. And I think the difference this time is we're not behind the counter, we're not in the basement. We're out talking to the patients at that point of care. And I think that's critical going forward.
Yeah.
Before I wrap up, I'm going to just take a couple questions. And if anyone has any questions, please add it to the chat. One of the first questions that came up is how mainstream is screening to biomarkers in clinical practice? And are there specific criteria to determine eligibility, including use of age as a factor? How mainstream is screening for biomarkers in clinical practice, and are there specific criteria to determine eligibility, including use of age as a factor?
There are a number of streams that flow into a given river, and so
Yes.
it depends on which stream, which mainstream you're looking at. I see some practices, small practices, health system, large health system, et cetera, that have fully adopted pharmacogenomics and multi-cancer early detection and other factors, sometimes with age as a criteria around probability of needing that data. Others, instead of age, might use the number of prescriptions you're on. So anybody who's on 2 or more prescriptions gets a pharmacogenomics test, that type of stuff. But then there are other streams that are equally large, maybe larger, where they don't know anything about it and you just don't see it happening. Ironically, there's less uptake in academia, in the academic medical centers, than there are in the community, partly because the academics often, we want to do it ourselves, and partly because there's no such thing as a perfect study, and therefore we're always looking for the next one. But we do see that seeing a lot of use of pharmacogenomics in particular, and some of these others in application. But I'd love to hear Thu and DeLon's viewpoint.
I think that a lot of times these types of tests, the question is always how much is this going to cost and how clinically relevant is the result going to be, because if the test comes out with a specific result and we don't quite know what to do with it, that's also going to be an issue as well. Being in the hospital system, and I've worked in several different health systems, there's a few that are very that have adopted the pharmacogenomic tests and are expanding that process and that program. And then there are others that would say, well, the guidelines don't recommend it yet. We don't know when or how to start testing our patients yet. So it's not as mainstream, but people are slowly warming up to the idea of it for sure.
Yeah, things are moving and shaking. I'm also a part of the North Carolina Precision Medicine Task Force, where we're looking to partner with legislators, along with clinicians, researchers, people in the VA, people in the community like myself, who have an aligned passion for putting PGX into policy, of course, for reimbursable purposes, for CPP changes. We know that that's long overdue. But outside of that, guys, deprescribing and genetic testing isn't going away. And the VA is probably going to be the bread and butter for that. For those who may not be familiar, the Vion methodology has been a widely successful deprescribing tool. Essentially, it's a mnemonic looking to assess which medications are vital, important, optional, needed, and every medication has an indication. But why I'm bringing this up is because there are some whispers about some PGX companies leveraging that same model of deprescribing with that genetic testing component. So we're going to start seeing more grant opportunities, more federal funding. Of course, there's already the All of Us federally funded campaign around genetic testing, precision medicine, where they're trying to get more minority recruitment, more representation, to have a little bit more equitable use of that data. But for what I'm seeing, is we're going to be seeing this scale. Like honestly, we're going to see this scale on a larger level. So biomarker wise, I don't really have much for you there, but what I can tell you is that the wave of this becoming adopted, the fact that Medicare can pay for it, Medicaid in some states, TRICARE covers it. We've got more insurers on board, mind you, more after the fact instead of like preemptively. But yes, the FDA is catching on board. CPIC is constantly updating. You know, Howard's heavily involved with the people that edit and make some of these guidelines. So it's really not stopping. And so I'm proud to say that I've been able to use the idea of using pharmacogenomics and Viome to roll out deep prescribing in faith-based communities. This is like my first ever deep prescribing grant, super psyched about it. But from what I can tell you is the community wants it. They just don't really know who's going to be the best vehicle to get this type of service. So I am so amped to see you guys just show that this is really a huge opportunity for pharmacists, but more so the betterment of our people who need.
One
Congratulations.
thing that came out there was the who's got your back part. And I know we've talked about it already, but in situations where there is expertise to rely on, adoption is much quicker.
Right.
And I think both Thu and DeLon's comments, kind of an underlying piece is they're working with people who can rely on them, can reach back for help, and that makes a huge difference.
Outstanding. From a community pharmacy standpoint, are PGX tests covered? Is there typically a copay? How would a retail independent pharmacy bill for these? And again, it kind of varies, correct? By state, by payer.
It very much does vary by state and by payer. We're finding more and more coverage, and some of the intermediaries, Evacor as an example, are now starting to recognize value and start paying for that for the testing. I mean, there always will be people who don't cover it, and they're in terms of the copay element, which I think was part of that question also. It really, I've seen it everywhere from it's covered, but you haven't met your deductible, so you're basically paying for it, all the way through to it's free because you have that kind of coverage and you're at that point in the year. So it's there. Many of the testing labs have a cash price, which is in the $200+ range. So it's not cheap, but it's not too bad. And so that's another route that I've seen some people go where they just, they're going to save their deductible for bigger expenses and just go ahead and pay cash for this.
Mm-hmm. Mm-hmm.
Yeah,
Yeah,
I see.
Go ahead.
Go ahead, DeLon.
But that's I was going to piggyback. It's traditionally what I see in the community setting of using it, especially with my model, which is more concierge based. It's for me, it's cash based. So we still have to get a ways to go to get this universally covered by all insurers and whatnot. And it's not always applicable, don't get me wrong. So from the community lens, there are some amazing things going on. For instance, I have to shout out Dr. Amina Abubakar, who uses pharmacogenomics in her Avant Institute clinic, also in Charlotte. And she partners with local providers and provide this service. Mind you, it is a cash-based service, but she's doing this through a collaborative practice with people locally. So it can be done, and it is being done. In fact, even one of our alumni of our deep prescribing accelerator, Dr. Tamara Ruggles, developed her own deep prescribing clinic, and she's using pharmacogenomics and leveraging her network of long-term care physicians and providers who are looking to kind of get some of those cases solved. So again, the opportunity is there in the community. I think a lot of it is how are you positioning yourself? How are you making those key partnerships? And how are you able to communicate the value of this service? Not to sell and kind of manipulate, but just to show the tenacity of this test and how pharmacists can take charge of this profession and this field.
Absolutely. I see one of the comments in the chat. It's something that a program we're quite familiar with as Genexus, as well as several of you have been involved. The Kentucky Teachers Retirement System, they do offer PGX testing to their over 65 members, and it's actually part of their benefit. And they have a team of pharmacists to support and review those results with the patients, and the outcomes have been tremendous. They do offer it to other members who are under the age of 65. There is some nominal cost there, kind of tying into what we're talking to here. It's coming together, or for certainly. But
And Jane Gilbert and Dora Moore and the others from the Kentucky teachers system have just done a heroic job of taking something that has value and making it happen. And patients and their families can choose not to partake, but it's available. The rate limiting step is not knowing about it or being able to afford it. The rate limiting step is it right for me? And I think what they've done is just really vaulted the field forward in the over 65, helping over 65 in their care be managed. It's a tremendous job, and happens to have favorable economics as well. So that makes it even a better thing to adopt.
Absolutely. Well, folks, that's all we have time for today. And any questions we missed, we'll be in touch with you. Any other questions you have, just email them to us at info@genexus.com. But I'd really like to thank the three of you, Howard, DeLon, and Thu, for this outstanding hour of time together. I guess some of the key bullet points that I kind of drew from our conversation is clinical collaboration and education is key. And it's not just with physicians, it's with other OT, PTs, MSWs. That's key to taking care of this patient population. It's deprescribing and using the tools and guidelines to optimize the patient's care and get them on the right meds and deprescribe the ones that could be causing some of those issues. And we talked about kind of an underpinning of pharmacogenetic testing. I also heard, I believe it was Howard, talking about the point of care testing too, for some of those tests that have come out. Another data point to get to the precision medicine and the precision prescribing for these patients. I want to part with, we talk about precision prescribing, precision medicine, and I got feedback that as a pharmacist, we don't prescribe, but I still think it's like the holistic approach to prescribing, and we're a key component of that. I thank each of you so much for being on the panel today, and I look forward to our continued work together, and I can't wait to see some of the successes you guys have going forward. Thanks again.
Thanks for having us.
Thank you so
guys.
much. Have a great day.